Welcome to the Researched RN podcast. I'm your host, Stephen Kuzmenko. In this podcast, I discuss new and interesting peer-reviewed research articles from various nursing researchers and other professional publications. In this episode, I'll talk about a letter to the editor published in the June 2025 edition of Critical Care Nurse titled An Approach to Manage Agitation. It's authored by Dayton and colleagues. And in this episode, I'll be joined by Dr. Kali Dayton, one of the authors. She's an ICU nurse practitioner. In this episode, we discuss the foundation of communication in healthcare and in really nursing. We talk about the long-lasting impacts of delirium, the many impactful stories that Kali has from patients that have been in Awake and Walking ICUs. And then she'll share some tidbits on how you can become an ICU revolutionist yourself. And so from listening, you'll hear from her how agitation management in the ICU really does influence short and long-term outcomes. Hope you like this one. Welcome to the Research RN podcast, Kali Dayton. I'm really excited for you to be on.
Thank you. Thanks so much for having me.
And I appreciate the connection on LinkedIn. You know, I've seen your work. I am an avid supporter, member, involved pretty significantly with the AACN, American Association of Critical Care Nurses, in my local chapter. I attend NTI. I'm actually waiting to hear back from an abstract for NTI. So your work has made itself known through AACN, and that's how I first heard about you. And it's pretty incredible what the images that you're putting out with people walking on a ventilator, not sedated. My background is critical care nursing, and I think I have maybe ambulated 2 people ever who were endotracheally intubated. But for you, that's like a Tuesday.
The norm. Yep.
Yeah, so that is pretty interesting. And so I've asked Kali to be on my podcast because I want to discuss this letter to the editor that she published in Critical Care Nurse pretty recently, June 2025. And in this letter to the editor, her and her fellow co-authors, there's a few people on this, they outline a protocol for agitation, how to manage people in the ICU who may or may not be intubated, but in general, agitation. And so I just wanted to break down this protocol, ask some targeted questions, maybe illuminate some of the things, because sedation's at the bottom.
Yep.
So you're probably ruffling some feathers with that. And so to start off, one thing that I noticed, agitation assessment, you find patients at risk, and there's possible issues that can contribute to agitation at the top there. And then RAS is going to be greater than or equal to +2. And then, so that's where you start. And that first box, I want to spend some time there. Perform prevention. I think one of the things that I noticed just reading those bullet points is like communication seems to be the core of prevention. And so I wanted to ask, is that lack of communication that ICU patients, because you've talked to a ton of ICU patients and you are a critical care nurse practitioner yourself, talk to us about that lack of communication that patients experience when they are not only intubated, but when they're sedated. How does that contribute to agitation?
I think that we obviously are better at communicating with patients that are not intubated, but we're not always great at that either, especially if they don't speak our language. I think we are very system-based in our approach and our perspective and our focus in the ICU, as far as this is a 76-year-old male with a history of COPD here for a COPD exacerbation that has an AKI, right? There's nothing about that human. There's nothing about their functional status beforehand, who they really are as a person, and nothing that humanizes them. And it's easy to just be like, they're on BiPAP and all these things that are important. But we don't always look at them as far as what do they want in their care, unless we're looking at end-of-life discussions, right? They come in and we're like, what do they want as far as, do they want CPR? Do they not? But not, do they hate having their feet tucked into the sheets? Do they hate being hot? Do they hate country music? Right? Like, but we're playing that in the background while they're sedated. So we don't know who this person is. So we cannot humanize the ICU unless we are understanding and caring about the human in the bed. And we cannot really connect with that person unless we are communicating to them and get communication back from them. And so that is like the fundamental pillar of really nursing values. We talk about patient autonomy, patient education, family education, respecting patients' wishes, all of these things that we learn in nursing school, right? That are in these papers and journals and whatever, and our mottos and themes. And then you go to the ICU and it's all out the window, right? Now it's a totally different ball game, or so we've been told, that, well, now they're on the ventilator. They can't talk, therefore they can't communicate. But internationally, there's been a declaration for decades that communication is a basic human right. So why wouldn't we fight to preserve that during patients' most critical, vulnerable, and potentially final moments of their lives? So there are so many things that can cause our patients to be distressed in the ICU. I mean, I love asking clinicians what causes the behavior of a RASS of +1 or +2, which is, +1 is when they're fidgety, +2 is when they're pulling on restraints, banging on the side rails, right? Going further into the RAS, +3 is when they're trying to self-extubate or pull out their lines and tubes. +4 is when they're getting combative and dangerous. But when we talk in the ICU amongst ourselves, call our providers, looking at sedation management, +1 to +4, although those are very different levels of psychomotor activity, we call all of that agitation, right? So if we're looking to meet patients where they're at and prevent escalation, we also need to speak and think in RAS. So if they're a +1 or +2, I ask clinicians, what could cause that? And we need to prepare for that. So I ask those questions as we're preparing for intubation. What can we prepare a patient for in terms of things that will be stressful, traumatic, uncomfortable, painful prior to intubation, if we have a chance, right? And so obviously, pain. The inability to communicate, being unable to talk is very stressful and traumatic. I host a podcast called Walking Home from the ICU. I invite everyone to go listen to episode 103. I have survivors and clinicians talk about the value of communication, but it is wild. The things that survivors experience as they were patients and were trying so hard to communicate, like, where are my children? Where am I? Is my dog okay in the apartment? I'm withdrawing from
Wow.
Wellbutrin. I have chest pain, right? Their nose itches, right? They have so many questions and concerns and needs that sometimes could be so easily answered. And yet, what does that look like to us? Their nose itches, it looks like they're trying to self-extubate. They're
Mm,
trying to signal that they want to write. It looks like they're pulling on the restraints, and we just assume it's going to escalate to self-extubation. We make all these assumptions because that's how we've been taught that our one job as critical care nurses is to keep that tube in for our shift. And we do whatever it takes to get that done. What we don't realize is that by having that prioritization of just focusing on the tube for our shift, we are giving and exacerbating acute brain failure. Delirium is acute brain failure. It is syndrome manifesting damage, neurodegeneration, and injury happening to the brain. That can happen for lots of reasons in the ICU, but sedation is the main modifiable risk factor. And giving sedation for agitation is not actually going to address any of those problems, if that makes sense. So if they're panicked because they think they are kidnapped and their organs are being harvested,
mm,
during our awakening trial, they come out crazy, right? And they're not crazy because sedation's been turned off. They're moving because we've taken off the chemical restraint.
mhm.
And resuming that sedation only resumes the chemical restraint. And survivors have explained to me it was like they barely got their head above water and got to take a big gasp of air
Wow.
and then got shoved back down.
Wow.
One survivor said it was like being in a Mad Hatter's tea party. And she remembers was probably awakening trial. She was writing on a clipboard. She knew she could hear everything around her while she was sedated. And she was, yes, a patient, but also a nurse. And so she was trying to like interact with these communications as far as, I don't know, where's the RTE? And she's like, oh, let's call so and so. I know he's on shift. He'll come up. Like she's interacting with everyone as if she was a nurse caring for the patient, but the patient was herself in
Wow.
her mind, right? But no, she's just laying there sedated. So when she comes out of sedation and she's confused, she knows that she's critically ill. And she is so eager to communicate with her son because she really knows that she could die. And she wants to talk to him
Wow.
during her potential final moments, right? So she's writing on a clipboard, and then everything goes dark again. The nurse
Mm.
had resumed sedation without consulting with her, telling her, telling her the risks of it, asking her what she wanted, nothing. Everything just goes dark. And that alone was very traumatizing to have the ability to communicate just taken away. And so, if we want to prevent agitation, we have to give our patients as much information, control, autonomy as possible and help prepare them for what's to come, as well as give them all the tools to manage what they're currently feeling. But we have a conveyor belt in our ICUs that takes that ability to communicate away in a couple of different ways, right? We've all inherited this culture of automatic sedation. The second anyone's intubated, no matter why they are intubated, they are going to be sedated because that is what we've inherited from bad practices in the 1990s when we didn't know the harm of it. Then, throughout the decades, we have discovered lots of lethal and life-altering harms of this sedation and immobility, but the culture has just clung to this automatic sedation. Now, the challenge with that is when we sedate patients, obviously we chemically restrain them in that moment. We take away their ability to talk, but they could communicate with us if they could write, right? And we've tried to do less harm by lightening sedation, avoiding benzodiazepines, and we know that that's less harm. But in reality, in that moment, if a patient is on propofol, even Precedix, at a RASM -1, -2, they cannot hold a clipboard and write on it. They can't tell us what they're experiencing, what they need. They are still chemically restrained. If they are given propofol, for example, for even just a short period of time, 24, 48 hours, they might have the muscle mass to hold a clipboard during that awakening trial, which I don't even like those phrases, but which you can talk about. But let's say you turn off sedation to see if they can be extubated, right? Or to check for delirium. You take it off and they look distressed. And you do want to know what's going on, what they need, what's causing this RASA +1 and +2. You give them the clipboard. How likely are they to be able to hold that clipboard and write? What's been your experience, Stephen?
Oh, I mean, sure they can write, but it's nothing's going to be legible.
Yes, and even our young, healthy patients, right? I put in quotations healthy, right? Because no one's like healthy, but even people that were more robust and they still have the mass to hold a what
Yeah. Squiggly lines.
half-pound clipboard, right? If that, they still can't hold it because the propofol has inhibited the sodium channels. So it's
Mm,
decreased muscle excitability. So they want to hold that
wow.
little pin.
And
They
their
want to
brain
hold
is
the
telling
clipboard.
them to.
Yep, they want to text, right? I mean, how innate is texting for our generation?
Yeah.
But they can't get their digits to do what the brain is telling them to. So we've disrupted that neuromuscular connection. And then what happens when they can't write on the clipboard or text? What happens for you, Stephen? Is that comfortable for you?
No, I mean, they get frustrated because you try, and maybe you say what they're thinking and you get it wrong. And then it's just they get frustrated, but that's human nature. I mean, how can you not if you're trying to communicate, you like you said, you want to, their brain is telling their hand write this and it's not happening the way they want. How can they not get frustrated and eventually, yeah, agitated, especially if they're not around people they know. That's a very vulnerable state that they're in. Uncomfortable.
And maybe they have delirium,
Yeah,
right? We
yeah.
also have to realize that not only does sedation impact the muscles as far as disrupting the sodium channels, it's also a mitochondrial toxin. So it rapidly causes not just muscular atrophy, but muscle dysfunction. But it also is neurotoxic. Propofol, midazolam, they disrupt the brain so that the brain cannot get REM cycle 3 or 4. So you take off sedation even after a few days, and now they've been absolutely sleep deprived for a few days. Then you give them a letter board, and they're supposed to point to the letters to write out a whole
Mm,
sentence. Absolutely not, right? So you're taking away their ability to write. Maybe they can write, maybe they're delirious and they think that they're writing something cohesive and now they're pointing at the letter board or the clipboard saying, Steven, can't you read it? And they just get offended. And then they don't know who you are. They're having a hard time trusting you because you don't even understand them. And they don't know why they're there. They don't know what's in their throat. They think their kids are kidnapped. They're just trying to get
Yeah.
out of bed to go save their kids.
Yeah.
It escalates, right? And so if we were to rewind and go back to the very beginning, if we have the opportunity before intubation to say, hey, looks like you're having a hard time breathing. We're going to put this tube down your throat. You're going to be sedated for the procedure. But when you wake up, it'll be shortly after intubation. You're going to have this tube down your throat. You're not going to be able to talk. That's going to be
Mm.
really stressful. But we want you to be able to be in as much control of the situation as possible. What would you like to communicate with? Pen and paper?
Oh, wow.
Cell phone? Okay, great. I will have that right here on your hip. When you open your eyes, your family's going to be right there and your hands are going to be tied down. I know that's going to be stressful. It's just, it's normal to try to pull that out. We're going to get those untied as soon as we know that you're more woken up and aren't going to go for that tube because you remember you're going to need it to survive, right? Okay, and then we'll untie it and let you communicate. Hey, family, your job when I turn the sedation off is to help them write on the clipboard and to stay calm and help them understand what's going on. Oh, also, this thing is strapped to your face, but you can't touch it or look at it.
Mm.
Uh, doesn't that make you go insane? If I, when I do simulation training with teams, we'll be talking and my trick is to go, like, I look at someone, I'm like, oh, hey, you've got something on your face. And they immediately go to touch their face. And I'm like, yeah, that's what we do. Innately, as human beings, we've got something on our face. We want to touch it. We want to see it. But when our patients are in the bed and they've
Mm.
got these huge things strapped to their face, down their throat, we're like, don't worry about it. Don't touch it. Don't look at it, but don't panic. Right? So, can't we have the family hold a mirror, put the phone on reverse so they can see a selfie
Mm.
so they can look at it? Can we not normalize this for them? And, it is such a different experience coming out of 20 minutes, 2 hours of sedation versus 2 days of sedation.
Mm-hmm.
That it's kind of like coming
Wow.
out of colonoscopy. You're like, hey, well, remember where we're at?
Yeah. Usually you
Um,
do. Yeah.
yep. And like they can write. So they may not remember. Maybe they were intubated in the field, in the OR or whatever. But that is so different for a few hours versus a few days, and that you can actually talk them through it. And when they can preserve the ability, like the cognition and the fine motor skills to communicate, you can identify their needs. They can identify their needs. They can express it. We can understand it, we can meet it, and we continue to reevaluate. And the likelihood of ever needing to sedate them almost dissipates. Now, if they are, RASA plus 4, don't give them a clipboard, obviously.
Mm-hmm.
That's not safe.
Yeah.
But what if we use dexmedetomidine to get them down to a RASA plus 1? And then circle back to, hey, what's going on? What do you need? What questions do you need? And addressing their issues, maybe it's pain, and we buy some time with a little bit of dexmedetomidine, some fentanyl to get like a long-acting pain regimen on board, then circle back to that dexmedetomidine. Our goal is not just to keep the tube in, it's to the give them the best chance to survive and thrive.
To be the
Being
same
sed-
person they were.
to be the same person they were before and to go
Mm-hmm.
back to lives worth living.
Yeah.
That phrase is from survivors.
Mm.
I wanted to go back to a life worth living. 12 years later, I'm not sure if that's what I have.
Oh, wow.
And a lot it's because of the trauma of being sedated. And we think that because they're laying there motionless, that they're not aware of anything, they don't have any pain, that they're comfortable, that they're sleeping. It's all a myth. They are oftentimes hearing and feeling everything around them at high risk of it being twisted into something much more traumatic, graphic. I don't even like to call them hallucinations because what survivors describe to me is what they experienced under sedation. Even though it sounds insane to us, to them, it was more real than what you and I are living right now.
Mm.
And if we were to really understand that, this is why I've interviewed dozens of survivors because they're the
Yeah.
most compelling. You can stand at the doorway or the bedside and say, hey, take sedation off. If a nurse thinks that that's what's keeping them, quote, safe, comfortable, asleep, they're not going to be very motivated to do that, especially when you turn it off and they come out crazy and the nurse has another patient to care for, right? That's the way the ABCDF bundle has been taught to nurses and reinforced is chart your SAT, chart your camp, chart your RAS instead of save their lives, They're
Mm-hmm.
giving them a way to communicate. If they're agitated, we can do something about it. But right now, I ask nurses, what's in your toolbox? If you have a patient that's a RASA plus one, plus two, what do you have to use to intervene? And they're like, sedation. That's all we have. And so, of course, that's all they use. So, when I talk about patients being awake and mobile, especially in the context of an awake and walking ICU, in which we don't even
Yeah.
give sedation ever, unless there's a medical indication for sedation, we can do that because we do other things instead of sedation. It's not taking something away, it's giving patients access to more. So, if we want to prevent a RASA plus three or plus four, in large part, we can do that by giving them a way to communicate throughout their journey, addressing and meeting their needs, um, and preventing delirium, right? One of the biggest reasons for agitation is because they're so confused and
Mm-hmm.
terrified. One survivor said that he experienced his father cannibalizing him on repeat for days, and he could feel every single bite. That is deeply
A nightmare.
traumatic. Absolutely. And so then you take off sedation, and he's still running from the
Oh,
Nazis in
jeez.
his delirium. And so of course he's going to be running away. And so if we prevent that, and we can't, oh, I don't think we're ever going to fully eradicate delirium, but boy, we set them up to have it and have it so severely when we automatically start sedation. So if we can take away the biggest risk factors for delirium, we will make our jobs so much easier and safer as nurses. Think about, if and when you've been assaulted, which I think most to all of us have, were those patients in their right minds? No.
No, it was an elderly patient for me, and I knew that he didn't intentionally do it, but he hit me in my arm, but it was okay, I guess. But yeah, like it's rare to have that I've seen to have true behavioral patients that are suffering from a, behavioral illness or issue that are aggressive. So yeah, I mean, it is likely now thinking about that. I mean, it is a complete paradigm shift, which you're explaining is I had when I was bedside, I mean, my propofol orders, my fentanyl orders it was just, oh, RAS is +2, go up 5 or 10 mics per kg, on your propofol. Give a push of fentanyl Q 20 minutes times three, and then notify the provider. But what you're talking about it's just a different approach to what is our goal with them being here, which I think is incredible. You laid that out so well. And one of the things that just blew my mind just as talking was you create to the best of your ability, of course, depending on their condition, you create a communication plan before you sedate them. I have never even heard of that happening.
It's because we haven't thought of it that way. I started my career as a nurse in critical care in 2012. And by then, that team had already been doing this for over 15 years.
Mm,
So this was never formally taught to me. It was just modeled to me. It was normal. It was like you say, "Hey, here we go. Let's do it." And you chat with them beforehand. You intubate them, then you wake them. Then they come out of sedation, those induction meds, and you're like, "Here we are." And so it was just so normal there that it wasn't until I became a consultant trying to get teams to do the same thing that I realized, oh my gosh, I have to teach that. Like, this is not something that nurses or any of the team members are actually experienced with. They've never seen it done this way. There is this like, welcome to the ICU. This is just the way we do it. And you kind of stop seeing our patients as human or
yeah.
as people that should be autonomous. And I say that because I experienced that as well. Because I worked in the Wake and Walk in ICU thinking it was normal to have everyone awake and mobile as possible. Then after a few years, I became a travel nurse and I went into a normal ICU and I
Oh.
was so confused initially that the lights were dark at 7 a.m. Everyone was in bed. They all looked like they were dead. It was so weird to me. And then I got a patient assignment and my patient was sedated. And I went to go do my normal routine, right? Everyone has their autopilot. And my autopilot was talk to the patient, get communication back from the patient. I mean, a pain assessment, I didn't even know really what a CPOT was.
Hmm.
Like I was used to my patients telling me what they
Wow.
experienced and needed. And then getting to the chair to wait for PT. Like that was a conveyor belt I was programmed to have in my practice. But I couldn't do any of that because the patient was sedated. I had no idea why they were sedated. There's nothing about their condition, acuity, ventilator settings. I mean, none of that really dictates sedation in my mind. So I asked the orienting nurse and why the patient was sedated or if I can get them off sedation, get them up. And she was just mortified. And we just went in circles about, no, she's sedated, she's intubated. And I'd say, well, I know she's intubated, but why is she sedated? And then she'd say, because she's intubated, right? We were speaking two different languages and going in circles. And, I was only 2 years into my career and I was surrounded by people that initially that had more experience than me. I was also just trying to fit into a very new environment.
Mm-hmm.
I tried to be that nurse that was like, hey, in my ICU, we do this and that. But then people would say things like, well, those were LTAC patients. That wasn't a real ICU. Those weren't sick patients. And I really second guessed myself. And I just thought, well, if everyone's doing it this way, I'm the visitor here. I'll just do it. And I really trusted that what was normal was benign. And I started to just get used to that. Like it's almost like the brainwashing washed over me. And I became to expect that. And then after a few years of doing that throughout like 10 other ICUs, I went back to that first ICU and almost had another layer of shock to be like, oh my gosh, hold on. What are we doing here? These are people that are really objectively sick. I had much better understanding at that point. I'm like, these are multi-organ failure patients, people of 18 and 100%, and they are
Wow.
awake,
Oh,
walking, texting on a clipboard.
wow.
And then I was like, why can they text? Or like, why can they write so well? And I had taken a contract in a neuro ICU, so I was like, well, maybe those weren't like more neuro patients. But looking back, I'm like, no, it's because I wasn't doing an awakening trial days to weeks later. It's because they were
Mm-hmm.
awake right away. And so it's been a journey of me piecing this together as far as why did it seem so simple in that ICU? And it's because what my mentor would teach me, this is Polly Bailey, she's the nurse that started this process of care. She inspired the ABCDF bundle. She
Wow.
said, what we do on the front end determines the back end.
Mm-hmm.
So what we do even hours after intubation can greatly impact what happens 5 days later, 2 weeks later, 3 months later, and even 10 years plus down the road. So as I've been training teams, I just kind of assumed they knew how to give them a clipboard. And then I'd be in the rooms and I'm like, okay, let's take sedation off. Where's your pen and paper? And they're like, I don't, well, let me go find one. And I was like, what do you mean you have to go hunt through the unit to find a clipboard? And you have like 10 intubated patients on this unit and you don't even know where a clipboard is. I still get hot and sweaty thinking about it because communication is so
Wow.
sacred. I mean, my own daughter is nonverbal. She has
Mm.
mitochondrial disease, and so it impairs her muscle function and control. But cognitively, she's totally intact, and she uses an eye gaze computer to communicate. So when people say, well, they're intubated, they can't talk, to say that they can't communicate, I get especially feisty now, right? But that's what we've been taught, right? Like it is, people are not used to seeing patients awake and calling the shots and knowing and understanding what's going on and protecting their own tube. I have had survivor or patients say, be careful with my tube. And I'm like, you don't trust me? I'm your
Wow.
nurse. But they know exactly what it's for. And I remember
Yeah.
during COVID, I heard a patient's alarm going off or ventilator. And I passed by the room and this patient is holding their tubing right next to their endotracheal tube. And of course we freak out and panic and gown up and jump in there. Her tubing had come disconnected from her endotracheal tube. And we, of course, reconnected it. And then we're like, oh my gosh, did you pull it off? Did you try to self-extubate? And she said, no. And then she wrote on the clipboard, she said, I coughed and it came disconnected. I was holding it there, keeping it
Wow.
connected, getting the, airflow that I needed. And I was like, yep, that's the safety. I mean, she was isolated in a COVID room. She had COVID. She was really sick. And yet, yes, she coughed, but coughing is not the worst thing. We want to engage those respiratory muscles. But because she was with it enough, you can dislodge a tube over like a bed bath or whatever, but she was able to keep taking her own breaths, hold the tubing herself. So that's something that most nurses have never experienced. We've just been brainwashed to expect every patient to be so unsafe, so confused, completely vulnerable, and that we just get to take over and assume what they want in their care. But then we suffer moral injury later on when we're providing terminal care later on and we're like, I
Yeah.
don't think this is what they want. But because we've sedated them and now they are suffering such a severe brain injury from delirium from the sedation and they're disease process is so advanced. Now we're leaning to the families to make their best judgment. And that causes us a lot of moral injury. I've had so many patients be able to tell me exactly what they wanted and sit down and have end of life discussions that were so sacred to me and, of course, to the family and the patient, where it's like, hey, your interstitial lung disease is at end stage. You can do a tracheostomy, but you will likely never get off the ventilator, or we can have a party. You can choose your guest list, whatever like sip or food you want at the very end, if there's time. Um,
Yeah.
your music, your decorations. You say, I mean, I have been part of extubating a patient on the helipad at sunset with the wife in the bed.
Mm.
That cannot happen if we automatically take away their ability to be involved in their process, to communicate, all those things. Um, so that's why communication is so sacred. And I just don't know how anyone can manage any kind of distress from a patient if they are walking into a situation where the previous shift and the previous 5 shifts before them have already sedated them. You can do simple yes or no questions. We should always be fighting for communication, but we're making it so much easier on ourselves and each other when we establish this pre and post intubation process and be asking every day, every rounds, clarifying how this patient communicates. Everyone that walks in that room should know, okay, they like to write on their cell phone. They like to use their iPad. And we go in with that expectation. That's when it becomes really cool to practice in that kind of ICU.
Yeah, I mean, shoot, if I needed ICU care, I want to be in an awake and walking ICU. That sounds like you're setting your patients up for success from the get-go. And as a new nurse, I don't think I really got an understanding of how detrimental delirium is, ICU delirium. It took me months and years to realize like that it has years impact after the fact. And I know I didn't know that. I don't know if that's been new or if that's been around, but I had to really learn that on my own what PICS was. And it wasn't really until I was an educator myself for critical care and delivering this education, trying to inform people because I was really focusing on the night interventions. And I know that you cited one of the studies by Gorecki. She is a CNS and she did a good study on how to promote sleep, a sleep promotion bundle. And so I was like, well, why do we need to we need to promote sleep? So we prevent delirium so that they are like the whole cognitive issues, the like the word you don't like to use, hallucinations, that I did not realize has such long lasting impacts. The days that they're in the ICU can impact them for months or years.
And it's really challenging to optimize sleep or implement that kind of bundle when we have sedation in the
Yeah.
works as a standard rather than the exception. So, awakening trials, here's the thing, my thing with those. Um, we created this conveyor belt of automatic sedation in the 90s when we were giving 10 milliliters per kilogram of tidal volumes during ARDS.
That's a
Right?
lot.
Your eyes got really big.
That's a lot.
Because
If
the
they need it,
theory
they need
was,
it. But
no, we didn't need it. The
oh,
theory
they
was
mm,
these are stiff lungs. Let's give them more volume, more pressure. And we, of course, were making these lungs explode. It was so
that's a lot.
uncomfortable for the patient. So we were left thinking, okay, how do we stop the patient from breathing? Because they're, quote, fighting the ventilator, right? So
Paralyze
that
them.
paralyze them. These
Mm,
barbiturates, benzodiazepines, opioids, these came up from the OR and entered the ICU. Before that, medically induced comas didn't exist. Intubated patients were awake. But when we did that, we were thought, wow, they don't do anything against the ventilator. That's easier. We didn't realize how harmful our ventilator settings were until later. And then we realized, wow, their eyes are closed. They're motionless. They're, quote, sleeping. That is so much better. No patient should have to experience the stress of the ICU. Let's just do that for everybody. And so that's how the conveyor belt was born.
mm,
And then in the 90s, almost at the same time, we had Dr. Ely publish a study showing, hey, if you turn the ventilator off every day, your time on the ventilator drastically decreases. Well, that makes sense, right? You can actually determine whether or not they need the ventilator. But then when this conveyor belt happened, they had to do another study being like, okay, now that we have this automatic sedation, let's also make sure that we turn sedation off first before turning the ventilator off. Okay, so we did that, and that showed less time on the ventilator, less harm.
mm.
And then with these turning the ventilator off and the sedation off every day, we started calling it things like daily awakening trials, and then that turned into sedation vacations,
Hmm.
sedation holiday, sedation interruptions. But what do all those words, holiday, vacation, interruption, what do all of those imply, Stephen?
That it's good. They should be off.
Well, yes, but if we say daily interruption, daily awakening trial, daily sedation vacation, that it's going to be temporary. We're going to do it every single day
Right.
because, of course, we're going to start sedation. That's assumed. And then we're just going to do it really briefly to
Hmm.
see if they can get off the ventilator. And then we'll resume it and do it again tomorrow. And that has really messed us up. So then how do
Hmm.
we work towards keeping patients awake and mobile? If we're automatically starting sedation, creating all these challenges to communication, leaving all these needs unmet, causing patients to become confused, then we're going to try to mobilize them once they're really weak and dysfunctional. That's not feasible. So another really important part of managing patients with the RASA plus one or plus two is to mobilize them.
Yeah, that was
And
something that I was really surprised to see pretty far down. You mobilize patients that are experiencing delirium.
that's our biggest tool. I mean, there's family, obviously.
Hmm.
So the main tools we have in the ICU are family engagement, not just presence, family engagement. So meaning patients should be able to look at their family members, communicate with them, hold their hands, actually engage with them, right? So family, real sleep, and remember, sedation's not real sleep, mobility, and avoiding medications that cause delirium. But when we put them on this conveyor belt, we obviously give them medications that cause delirium on top of all the other risk factors they have for delirium. We take away their ability to mobilize, their ability to get real sleep, and their ability to engage with their families. So we are really messing up our delirium management with this conveyor belt. Um, but it is amazing in live time to see what happens when someone is delirious and if they're getting worked up. So they're ASA plus one or plus two, they're fidgety, they're restless, they're anxious in bed, they're pulling on the restraints. Part of this brainwashing is we want that patient to hold completely still. If we make them stop expressing their distress, that means that the distress is gone.
Hmm. Because we
And
can't
we can
see it.
just, yep, if we give them sedation, they won't fall. They won't
Hmm.
self-extubate. Instead of realizing if we give them sedation now, we exacerbate and prolong this delirium, and they're much more likely to fall after
Yeah.
extubation on the acute care floor in the sniff, right? They're also, every day of delirium increases the risk of death by 10%.
Wow.
And if part of that distress is delirium, what sense does it make to respond to delirium with a deliriogenic medication? It's like giving bacteria for sepsis,
Mhm. Yeah.
which sounds appalling, but that is the reality of what we're taught to do. And no nurse is trying to do this, but this is the way that they've been taught. So why would they do anything different? So in that moment of distress, we need to obviously identify what do they need? Are they experiencing? Are they in pain? Are they worried about their cat getting fed? Are they worried about their mortgage getting paid, right? There are so many things that you would never guess in a yes or no question. So we need to try our best to communicate with them and get whatever we can out of them. But if they're delirious, they may not be able to do that, right? Then let's set them up at the side of the bed. Let's see what they can do. And I know we're so afraid of mobility, but throughout tens of thousands of mobility sessions documented in our literature, there's a 0.6% adverse event rate for early
Wow.
mobility. They are much more likely to self-extubate if they lay in that bed and writhe in delirium. They're much more likely to calm down if we get them sitting up, engaging with their family, put their family members right in front of them while they're sitting on the side of the bed. Put a walker there and have the patient hold the walker. Now their hands are connected to something. They're busy. Put their family members' hands on top of those hands. Now
Hmm.
they're physically connected, and you've also got someone babysitting. Now, while you do that, now let's do a bed bath. Let's clean their back. Let's swap out their linens. So it's not this whole extra thing, right? We put in some effort up front for hours of reward. I think about this when I was this last winter putting snow clothes on three little kids, my three kids. And I was like, this is so much work and I'm sweating it out. And I'm like, this is taking like 10, 15 minutes. This is ridiculous. But then I also knew that it was going to exhaust my kids to go out and play in the snow. I was going to get like an hour of peace,
Mm. Yeah.
right? While they played in the snow. And then
That's.
also they were going to hit their nap time and it
Hmm.
was going to make the nap time go longer. So I was I was doing my future self a favor, right?
Yeah.
And so we're doing that when we put that upfront effort in to sit them at the side of the bed, do those simple things, stand, walk to the chair, stand and pivot. Like the the distress just dissipates. And it's something that you would not believe until you actually see it. And I had so many podcast listeners reach out and tell me the craziest stories where, a patient's just wild and they slam them with whatever sedative. And then this podcast listener, who I call revolutionists, people that see it this way, and they're the only ones in their units that really see it this way, come in and do the unthinkable, right? They actually talk to the patient, sit them up, reorient them, and then they exhaust them. They lay them back down, and people come to the doorway and they're like, "Oh my gosh, what did you give him?" And I say, "Nothing. Mobility. I gave them mobility."
Wow.
So you think about your aging patients, especially. I can't imagine trying to keep people off of sedation without having mobility in my toolbox. As a night nurse in that Awake and Walking ICU, I walked my intubated patients. There was no PT or OT there. That was in my scope of practice.
Yeah.
So when I also worked day shift, I was like, oh, that's so nice of PT and OT to show up and do like help me with my job. That's really nice of them.
Wow.
Instead of it's only their job. If my
Yeah.
patient was sundown at 2 in the morning, it'd be like, okay, let's get up and go for a walk because I'm not coming in and out of this room all night. I'm not doing this. Like an Ativan wasn't even in my toolbox. And really, what sense does that make? 1 milligram of Ativan increases the risk of delirium by 20%.
Wow.
So again, we're just like locking and loading them into this cycle. And so we can get them off that roller coaster by mobilizing them. They wear out. You've got hours of peace, if not more. We need to have that as part of our standardized skill set in the ICU. And that's currently not there. Nurses don't even know it's in their scope of practice. They're afraid of it. They've never seen it. They've never learned how to do it. It's not even realistic to expect them to do it unless we create an environment and the training to make that
Yeah.
feasible. But once it's in their toolbox and they get confident with it and they see the power that it has over behavior management and getting patients off the ventilator and getting better and walking out the doors, there's no turning back. This thing that people say we can't get our nurses to do it, I'm like, I dare you. Try me. Give me like a few weeks with them.
Yeah. Yeah.
And they're
You're
going to be stoked about it because no one wants to wrangle a delirious patient their whole shift. And that's what they've said. They're like, I would much rather have a patient awake and intubated right away than
mhm.
have any delirious patient, no matter what they have going on or who they are.
Yeah, I mean, the interventions that Kaylee is talking about is really helpful when RAS is greater than or +2. Mobility is there. I was really shocked to see that. And I mean, I completely echo what you're saying as a former critical care educator. Nurses don't feel comfortable mobilizing. I think it's really a matter of what they think what they don't know what patients can handle, and they're afraid to assess because they think everyone's just going to fall. But I think it's also preceded by none of the things about communication or the minimal sedation or no sedation is used. So they are 3, 4 days in a bed, sedated, and so they are going to be really weak. And so yes, mobilizing that kind of patient, I'm going to feel more nervous than if they were, I mean, only sedated for a few hours and now they have most of their strength or it's essentially back to normal. I mean, so that it makes a clear difference for me and I would feel much more comfortable mobilizing that patient. But I think the issue is that they're just on the front end, like you said, that initial work is going to even with sedation, that work of setting up a communication plan from the get-go, which I think is a complete paradigm shift in critical
Hmm.
care, that is going to set you up so much after. And I don't think people understand that. I think you're seeing that that's part of the service that you provide, which I think is awesome. Now I'm really understanding what you do, and it's pretty incredible.
I want to share a little bit of a story of a podcast listener that who's a physical therapist, and they had sent me an email that they got from a colleague. It was a nurse, and the nurse was being really tactful and trying to express themselves, and it was fine. It just showed this disconnect of our different approaches. So this patient had been on high doses of propofol, um, and this physical therapist is very concerned about that, right? And this is an environment in which the physical therapist has kind of established herself as the nosy one that will come in and if no one's even asking her to come see the patient, she's like, hey, what's going on with that patient, right? So she gets the nurse to turn the sedation off, which the nurse was probably already titrating it down, but she said, I know I need it off because I'm here. Let's work with the patient now. There's no reason. This patient was on very minimal ventilator settings. They needed to be extubated already. And so they turn sedation off and the patient comes out RASA +2. And she goes, okay, let's work with this patient. And the nurse was very nervous. And so they turned sedation back on, now to a RAS of -1, which technically 0 to -1 should be within the parameters. But how beneficial is that to have someone at a -1, kind of open their eyes, still hungover from propofol, left to the physical therapist to sit up, right? The physical therapist is like, I would rather him be a +1 or +2 and use that momentum to sit up, have him fully working that sedation out so he can engage with his family. We can work through this. But the nurse was so hesitant because the patient was, quote, agitated. And this is my problem with our awakening trial algorithms that we have from the early 2000s is a failed awakening trial criteria includes agitation, but it doesn't have a RAS score with that. It doesn't specify. So that's something I have systems change when I'm working with them is you better put a RASA +3 or +4 as an indication for sedation, and it still should only be to a goal of +1 because otherwise we can't save them from whatever's causing this. We just mask it for longer. So this nurse was just very frustrated with this physical therapist and their interactions. And of course I wasn't there, but it just showed the difference in that. Here was this physical therapist saying, this patient has delirium. This sedation is not fixing the agitation. And the PT explained to the family that sedation is not sleep, that it can cause hallucinations, and inviting the family to help, to say, hey, talk to him, keep reminding him where he's at, why he's here. We don't want to keep the sedation going. The more you interact, the more he's going to calm down, the sooner we can get this medication off because he's so close to getting extubated. But that nurse was very upset about her informing the family of the risks of sedation, which I think is a huge ethical dilemma.
Yeah.
When else do we give such high risk interventions and don't disclose the risks, right? We do that. Anyone that goes into surgery, it's any minute, tiny little risk of anything. We disclose it and there's informed consent and they sign. But when someone's going to be intubated and we say, this medication could drastically increase your chances of mortality, time in the ventilator, brain injury, depression, anxiety, PTSD, physical impairments, X, Y, and Z. We don't say a word about it. And if
No.
someone does, now they're on a hit list. The team will turn against them for, quote, fostering mistrust. But families trust us to tell them the risks and to disclose that information and to give their loved ones the best chance. And yet we're not doing that.
Wow. That is incredible. Yeah, and it's very powerful what you're saying, and it's like I just can't I can't describe it any other way than a paradigm shift because to me, yeah, that would be unheard of if that was disclosed. Like, why are you saying it that way? But you really are telling them what they should know. And I think the success stories that you have clearly demonstrate that it can work. And so for nurses that are listening to this, how can they start to, if they want to become a revolutionist, the term that you mentioned, how can they get that started? Can they approach a provider, their CNS, their educator? How can they get started if they're interested in implementing this kind of approach?
Absolutely. That's why I started the podcast, Walking Home from the ICU, because I came to appreciate how much there is to explain. Because it's really hard to break down what we've always believed to be true. It's almost like telling someone the world is flat, right?
Hmm.
Or at least that's how it's perceived. Like there's no way that's true. So, in sharing the podcast, Walking Home from the ICU with your colleagues, if anyone wants, I've got little flyers made out for different disciplines. So here's a Google folder with flyers for physicians, for RTs, for PTs and OTs, for nurses. They have pictures of patients awake and mobile or just little facts saying, is sedation sleep? Hear it from those that have lived it. QR code. So that they can hear it from those that have lived it. I just stand by the fact that survivors are the most compelling. I'm obviously very passionate, but what I've been able to accomplish with these teams is because I've brought survivor testimonials to the table. And then obviously the tools actually change it. But just start with sharing the why. sharing those testimonials, people will quickly shut down and say, we don't have the staffing, we don't have the resources. To that, I would invite you to check out abcdefbundle.com. It goes over the financial benefits of the ABCDF bundle. So that quickly answers that question. Just again, starting to do it with your own patients. So as you take sedation off, give them a way to communicate. Get your therapist in there, get your colleagues in there and say, let's set this patient up. Let's get them moving. Let's get the family in here and start to build up that own skill set yourself. Build up those success stories. Get your patients reoriented and then have your colleagues see what's going on. Have them prove it to them. Seeing is believing. So pick an easy patient, more simpler patients, wake them up right after intubation. That's the best way to start, is to have them awake right away, write on a clipboard, and then try to get them to a chair. And they're likely to be able to get themselves to a chair, holding the tubing, and have your colleagues come and see this intubated patient sitting up in a chair. That's one of my favorite things when I'm with teams, is to do that right away and for them to be like, wow, we just intubated that patient a few hours ago and now they're in the chair. And why not? There are very few contraindications to mobility. And so just start with those little successes one by one by each patient. And then, you're welcome to reach out to me. I've got lots of resources, been doing lots of work on this to try every which way to build a revolution. And it's building. We've got symposiums in the works, just lots of opportunities, webinars that people can tune into. AACN has a webinar that might be a good resource to share with your nursing colleagues. But just start evangelizing.
And plug where can other people reach you? As we close this podcast? I appreciate your time. Where can people find you? What social media outlets do you have?
I'm on LinkedIn. So if you look up Kali Dayton, as well as Dayton ICU Consulting, I'm on Instagram, Dayton ICU Consulting as well. I have a website, www.daytonicuconsulting.com. You can email me from there, set up an appointment. I have all podcast episodes and transcriptions with citations on that website. I've got over 200 episodes for clinicians, articles. So there are lots of resources where you can go and listen. You can search by keywords. If you're like, okay, well, I want to hear from survivors that have actually been awake and walking. Wasn't that traumatizing? Go look it up. They're there.
That's awesome. Yeah, I appreciate your time so much. This is really incredible work that you're doing, and I do hope that I honestly don't know how many of my listeners are just critical care, because the episodes that I cover are kind of all kinds of specialties. And of course, I'm biased because I'm from critical care, but I'm trying to get out of my comfort zone and cover other research articles and quality improvement initiatives such as this, so I appreciate your time and sharing all this information. So thank you so much for being on the podcast.
Thanks for the opportunity.
And that is a wrap on this episode of the Researched RN podcast, your virtual journal club on the go. I am your host, Steven Kuzmenko. I'll have new episodes out at least monthly. You can email me at researchedrnpodcast@gmail.com with any articles or topics you'd like for me to discuss. Connect with Kaylee and I on LinkedIn. And if you enjoyed today's episode, please share with a friend. And it'd also be a huge help if you gave me a positive rating so others can find me. Thanks for listening, and be sure to tune in to the next episode.